Good morning, dear colleagues, dear friends. I'm really happy to be on UROONCO today with Professor Witjes. It's really a pleasure to have you on board today to discuss the release of the new muscle-invasive bladder cancer guidelines that you have shared. Please, Professor Witjes, can you tell us what is new in the guidelines this year?
Okay, bonsoir, bonjour.
Bonjour, yeah.
So I think if you look at the local situation, so the bladder cancer itself, we have made some progress with local imaging. It has been already discussed on this Congress a few times. And I think in the very near future, MRI will have a very important role in local imaging of bladder cancer, not only to see whether it's a T2 or T1 or T3, but also considering that you give neoadjuvant chemotherapy, that you can follow the response to neoadjuvant chemotherapy. And imagine that if you have a complete response to neoadjuvant chemotherapy, and it's proven by MRI, that you might even save the bladder, that you do bladder preserving
and skip the TURBT.
Maybe, yeah. Well, that's another interesting path. There are trials being done that if you see it is an invasive tumor, you can do, or of course, a TUR to prove it's an invasive tumor, or say, well, you know, we know that's an invasive tumor based on MRI, take a biopsy to have histology, and then you spare a TUR, you spare a lot of time, you spare some money, and there are trials running to see whether that's a cost-effective way, whether it's better overall survival, quality of life. So again, MRI will be very important the coming few years.
Okay, great. And after, I think in the guidelines, more in the metastatic, or at least at the extension of the bladder, you had more news.
Yeah, not more news. We have a lot of news which was already presented last year at ESMO and this year at the ESCO GU. So and we significantly changed the guideline, because up until last year, standard therapy for metastatic bladder cancer was, of course, cisplatin based, based on the 85 trial from Noah Sternberg and the 98 trial of GEM-CIS. Yeah. And there have now been 2 trials proving that there are better options. And one has combined GEM-CIS with nivolumab and then nivolumab maintenance, with a almost doubled progression-free survival and overall survival compared to a GEM-CIS. And the other trial, which is now actually the first choice in our guideline, is the combination of EV and pembrolizumab versus chemotherapy. And there was an almost 3-fold increase in the overall survival. That's really great news if you compare that to the very modest progression that we had in the last, let's say, 30, 35 years.
Yeah, definitely.
So now the guideline has significantly changed. First choice is EV plus pembro. If you don't have pembro or you don't have EV because it's not available, maybe.
And available in your country?
It is, yeah. So the second choice would then be GEM-CIS plus nivo. And if you don't have that, then you might go for
CIS?
Yeah, cisplatin-based chemotherapy, which is actually the old advice, old recommendation. And all recommendations are strong because they are large phase 3 trials.
Phase 3 trials.
Yeah.
So that's a huge breakthrough from the previous guidelines.
Absolutely.
And did you change any guidelines regarding to the perioperative systemic therapy in bladder cancer after cystectomy?
Not yet.
Not yet.
What we had is that neoadjuvant therapy is still neoadjuvant chemotherapy. There are trials with neoadjuvant immunotherapy, but they're not mature yet. And what we already had in the trial, in the guidelines, is that additional treatment in patients with bad histology, T3 or N+, should have, after cystectomy, immunotherapy. So that hasn't changed. Today we heard the preliminary overall survival data of the Checkmate 274 trial. And they also look favorable, certainly in the ones that are PDL positive. Perioperatively, what we also have addressed, and that's going to be discussed on Monday, is the large SWOG trial about a lymph node dissection compared to the German trial on lymph node dissection. And both trials, a little bit to my surprise, because you know I'm a surgeon, didn't show any advantage of an extended node dissection.
So how did you change the guidelines regarding that point?
Well, what we already had in guidelines, that you have to do a node dissection. We never specified
if it was extended or...
We did a review with the guideline panel some years ago, and then there was actually no real proof for whatever kind of extension you would have to choose. But now we have, with a little bit differences in how it's defined. We have now really from 2 large trials the proof that an extended no dissection doesn't improve outcome. It only adds more morbidity and even more mortality. So that's really something that will probably change how urologists will think about a no dissection and deal with that.
Great, fantastic. And regarding imaging, did you make any progress regarding the use of PET-FDG? I know, well, we all discussed on how and when to use PET-FDG in bladder cancer. Did you make any changes?
No, we didn't. You know that we had a review from some people from the guideline about PET, FDG PET. The problem is, and that was also addressed in one of the sessions today, that there still is actually not enough proof. If you ask me, I think that for imaging metastatic disease, oligometastatic disease, there will be a role for FDG PET, but we have to realize that you also have more false positives. So I guess it will change the therapy in 10-20% of patients, and the future will learn whether that's worthwhile, also costs, availability of FDG PET. So that's again something that will probably change in the coming few years into a hopefully clear recommendation, yes or no.
Okay, so as a conclusion, you improved the performance of MRI or the use of MRI in local disease.
Yes.
The main changes remain first-line treatment in metastatic bladder cancer.
Absolutely, yep.
With the 2 new randomized clinical trials, and we have some hopes for perioperative systemic therapy and PET for the future.
Yep.
Professor Witjes, thank you very much. But before you leave, after more than a decade as a chairman of the muscle-invasive bladder cancer guidelines, you're on time. You're going to leave soon and leave the chair.
Yep.
So can you give us, like, I don't know, your feelings of what happens during the last 10 years for you as a chair of the guidelines, and how you have seen the evolution of the muscle-invasive bladder cancer field change?
Well, I think what we are now doing, hopefully, is more personalized therapy. You know, when I was in training and even the beginning of the century, one size fitted all. And now we're trying to individualize therapy, both surgery or maybe trimodal therapy, which has come up a lot the last 10 years, or metastatic disease. Are you going to give chemotherapy or not? You know, not everybody profits from chemotherapy. In the neoadjuvant setting, there's a lot of been changed. So I think in all, more personalized therapy. So treat the ones you have to treat and don't treat the ones that are not going to profit from that. I think that's the major change, and that will absolutely be also so in the next decade of coming years. Yes, absolutely.
Okay. Professor Witjes, thank you very much for your time.
Welcome.
And I wish you a good time now and good holidays after these long times in the muscle-invasive bladder cancer guidelines.
Okay.